Hey, other sites, if one has a sound issue, just...
So Deb was down there. You couldn't... That procedure
back.
10 minutes.
Just try to make sure that all the microphones are working for these days.
I think we've... This is Jeff.
Yeah.
I can introduce her too.
All right, get started. I want to make sure that Dr. Butzell and Jessica have enough time to present today. So, Jessica Weber is the acute care NP and valve coordinator over at the Maine Medical Partners Cardiology, and she does the work together in an effort to coordinate the valve program, and Jessica's going to be talking a little bit about how the program works. And Dr. Butzell is going to be giving us an overview of TAVR and the clinic at CME and explaining to us the general procedure and who is a candidate for this procedure. Dr. Butzell attended the University of Rochester School of Medicine and completed his residency in internal medicine and his cardiology fellowship at Rush Presbyterian Hospital, as well as an interventional cardiology fellowship there as well. And he's been just giving me a little insight into this program. It sounds really fascinating, so I think I'll let him get underway. So thank you.
Okay, thanks for having us. So we have all flavors of folks in the room, I take it, advanced practitioners, docs, mostly nutritionists or OB folks around, or adult medicine? Okay, we'll take it. I just got back from Tanzania, Africa. And before we went to Tanzania, I used to work in Mozambique. So I told my kids, 2 teenagers, that someday I would bring them there, and we just did it. So this is related to valves, I promise, and it's also related to intermed. So I dutifully went to the intermed travel clinic before I came. I got my shots. I got, counseled on not to drink anything but bottled water. They checked my prostate again? Is that a new thing that intermed does? I don't know. I didn't know. I was going to talk to Patty about that. But so anyhow, my PSA was normal, and off I went. And I was given prescriptions for some antibiotics if we needed it. And off to Tanzania. So that's the family. That's my wife on the right and 2 teenagers in the middle. And everything started off very well. That's Chloe. She's 16-year-old. And survived 16-year-old daughter growing up yet. That's among feelings in those folks. So up here, I know you're there. So right. And started off great. And there's a little elephant in the back, and nice calm giraffe. And it seems like everything's going well. No real risk being here. A little baboon baby, cute, nice. Just cuddling. It still looks like the trip is going to go well. Still, we'll have something to do about intermed or valves, I promise. It's starting to get a little more dangerous feeling. There's like packs of roaming lions around, but pretty cool. The cubs are there. Peaceful scene still, more mothers and cubs. Now we're starting to ramp it up. So that's a leopard napping in a tree. And the leopard woke up, jumped off the tree, killed a gazelle, ripped out its throat, pulled it up the tree, and let its cub devour the rest of it. So now we're getting real. I'm like, it's the real deal. Blood is an amazing animal. There it is with blood all over its snout because it's just tromped on a gazelle. So looking back, I should have thought to myself, somebody giving me a sign that something's going to happen here because it's starting to get more violent. So we go to this picnic area. These are what these vehicles look like. And I sit down, have my picnic, and I lean back with my hands on the back of the bench, and all of a sudden I feel this very sharp sting. And oh no. So I look down, and dude sitting right there. So anyone know what that is? It's called hyrax. It's an African mangy rabid rat. So and that thing got my index finger. You know, I use my hands. So, but thanks to Intra Travel Clinic, I had my zithromycin on me. I bled my finger. I took my Z-Pack, and the finger's still there. And then I got back. I got tested. I asked the travel clinic about rabies. They said, you don't have to worry about it. There's never been a transmission from a small mammal to a human for rabies. So I learned something through the travel clinic. Apparently, if a small mammal is going to get rabies, it gets it from a big mammal with rabies and kills it when they bite it. So they don't survive to give it to a human. So, because days by the time I got back, and I figured I'm either a dead man or it's no big deal. And I decided to take that risk because the type of guy I am. So that's the travel clinic story. So thank all of you guys for saving my life. Today we're here to talk about the valve program at Maine Medical Center. And the valve program has been around since 2012. We're in year 6. We started off as a very, very, very small group of surgeons, 2 interventional cardiologists, 2 clinical cardiologists, and 1 research nurse. And 6 later, we have every single heart surgeon at Maine Medical Center as a part of our valve team. We have 3 interventionalists, 3 cardiologists. We have 2 advanced practitioner first. We've got secretaries. It's a huge, huge valve program. We patients at least 3 times a week, sometimes 4. We do procedures 2 times a week. And the amount of referrals that we are plugging through and processing on a weekly basis and a monthly basis now continues to grow. So it's really been an amazing process of growth through these 6 years. The heart surgeons and the cardiologists are now, we really are absolutely one. It's had some great benefits for how we treat patients with multivessel coronary disease too, because there's just no walls between the groups now. So, but move on. I can't keep on. So the disease that we're dealing with in our clinic, aortic valve and aortic valve stenosis. You can see cusps of the aortic valve and kind of cauliflower-like stuff. That's just bulky calcification, degenerative aortic valve stenosis. The mitral valve is over here. That looks much more pillowy. The mitral valve, oftentimes, as you guys know, degrades through time and becomes very regurgitant. And so the disease processes that we deal with most in the clinic are kind of the stars of the show, in a sense. These are the devices that we put on sticks and shove in these patients and treat them without opening their chest. So this is a TAVR valve. We bought a few for people to play with, and then something called the mitral clip, which advanced, and you clip the mitral valve shut to help with severe mitral regurgitation. So we'll go into these systems a little bit more today. So lots and lots has changed over the last 6 years. I'm going to try to highlight aortic stenosis and how the indications have changed for TAVR, because if you have ever heard of TAVR before, you probably thought of it as a procedure that was offered to patients who were very, very, very sick and couldn't have open heart surgery. Now TAVR is indicated for almost anybody with severe aortic stenosis. So we'll go through some of that. I will do a study or 2. We'll try not to get into data too much because I know you guys are busy and that'll lead to a nap. So, I mean, this is us. So we love valves, and this is what we really, really, really want to emphasize today, patient-specific solutions. So we are not is a TAVR clinic. There are a lot of valve teams that are TAVR clinics, meaning patients come in, they qualify for a TAVR, they get a TAVR. There are many, 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 many subtleties as to whether a catheter-based solution is the best thing for a patient. And we really feel that honest assessment of what's best for the patient is what's appropriate. We saw 4 patients in clinic yesterday. 3 of them we sent to open heart surgery. 1 we chose TAVR on. There's been a lot of improvements in surgical techniques. There are actually TAVR-type valves that can now be put in with an open chest that have pump run times much, much, much shorter for open heart surgery. So there's a lot more to offer than just cool devices on sticks. So we have consultations for all valve issues. If you have patients that have multiple valves that are mild to moderately leaky and it just doesn't feel comfortable, you know, as cardiologist, Dr. McGrath sends us patients so that we can just wax poetic without those things. The patients, when they come to our clinic, are seen in one room by a sometimes overwhelming number of doctors. So we walk in there with an interventionalist, a cardiologist, a heart surgeon, a test coordinator. Sometimes that is a little overwhelming for the patient, but our hope is that they experience many brains and many people involved in their case asking questions. And that allows us in real time as a team to decide which way to go with those patients. So we all do those catheter-based procedures, but we all offer hybrid surgeries. There are times where we will do an off-pump heart to LA bypass, and at that same sitting with the chest open, put a TAVR valve in through the aorta. Saves the pump run time, so no one's heart has ever stopped. We do sort of funky hybrid situations. And there are all these minimal aortic valve surgeries using the TAVR valves that I mentioned before. Some of these valves just spring open, made out of nitinol. They have memory. So if Dr. Reed Quinn's opens the chest, they're put on the pump, the chest is open, he can put a valve that just springs open on its own, gives you the advantage of cutting out the old valve so all the calcification is gone. When that valve springs open, it's going to be a perfect fit, closes the chest in 6 minutes as opposed to 40 minutes. So it's a real dynamic discussion. When we see patients, we got to really figure out what the risk of surgical complications are, and then depending on how high or low that is what technology is going to be best for that patient. Actually, I'll stop there. Any questions about that kind of stuff or how we see patients? Like, I don't know if any of you guys have had patients come back and talk about their experience through the clinic, but if they're bad, we'd love to hear about it. Okay. So we'll put all that effort together. This is the kind of growth that we've been experiencing. It's just been crazy, absolutely crazy. So we started doing about 12 procedures our first year, and then we just keep going up and up and up and up. And that's a combination of the technology, the equipment getting better and smaller. We can get it in through legs more often, as well as the indications getting wider and wider. This is a breakdown of actual TAVR procedures per year. This year, we're probably on track for 200 procedures. People sometimes ask us, why are the surgeons into this? Isn't this a turf battle? Why are all the surgeons on the team? Why do they love this? Why do they endorse it? And the reason is this. It's a little bit of a hard slide to understand, but the red is surgical mortality for open aortic valve surgery. Our program started in 2012. You can see before 2012, the red line was about here. So about an 8% mortality for open surgery. Whenever hit, it went 0. There was a 1 blip in 1 year, but 0. So the surgeons not only like getting their hands on the catheter and having new skills and all, but when they see patients with us in clinic, if that patient smells wrong, even their STS score is low. If Dr. Grass, Dr. Buchanan says, this does not feel right to me, we do a TAVR, and that has completely unloaded their surgical mortality for them. So it's really been pretty amazing. So here are outcomes. 0% surgical mortality, as we just talked about. Each year, 2 to 3% of patients won't make it out of the hospital. Often there are patients who are already in the hospital, in shock, very, very, very sick. 1% stroke rate, which is very favorable compared to a 3% stroke rate for open surgery. About a 9 to 10% permanent pacemaker rate. So when you squeeze a valve in an aortic annulus, you also ding the nerves that go through there, the conduction system. So we do talk carefully with patients that you may wake up not just with a valve, but the next day you may get a shiny permanent pacemaker if we put you in a complete heart block. Some TAVR valves with a little bit of back leak around them. They come in 4 sizes. They're all round. If you look at aortic annulus, none of them are round. And so we do the best we can to get the perfect fit, but we sometimes get a little back leak around that. That's gotten a lot better through the years. If you have a lot of back leak, it's a big deal. Those patients don't do well. The recovery time is really incredible at this point. Most of our procedures are performed through the leg. We put stitches in at the end. They're woken up immediately, and they go home post-op day 2 or post-op day 1. 2 go home post-op day 1 on Wednesday. It used to be a 5 to 7 day hospital stay afterwards, but now people turn around very, very quickly. And approved indications. This is really what's changed so much. So we started off with patients who are real symptomatic with severe aortic stenosis, who are inoperable. Then people with very high surgical risk. Now people who are intermediate surgical risk are approved. That's basically anybody who's over 80 with aortic stenosis, which are the people who have aortic stenosis. We can perform TAVR on people who've had open heart surgery in the past with a surgical valve put in, and that surgical valve is worn out. We call that valve-in-valve. And we even can put a TAVR valve in the mitral position for people who've had mitral surgery and it's worn out. We go up through the right side of the heart, poke a hole in the septum, go down through that surgical mitral valve and place a TAVR valve there. So there aren't many people out there now who don't qualify for TAVR, and there'll be none in another couple of years, because right now we're participating in standard low surgical risk patient trial. We're participating in a trial of people who have severe aortic stenosis who are asymptomatic, and people who have just moderate aortic stenosis but who have had heart failure. If you're with aortic stenosis, think because the turn time is so quick, the durability of these valves are very, very good, and there's not a reason to do it. Their anatomy is okay, which we'll go through. So, some indications before we go. So the classic teaching is to wait till people get symptomatic. Is that how you're still thinking of things, Peter? Yeah.
I mean, yeah, it's a variable.
Yeah. Yep. So those asymptomatic patients are they're really very rarely asymptomatic when you really drill down on them. And those asymptomatic patients, if you do the watchful waiting for too long, will sometimes come back with an ejection fraction that went from 60 to 30, or really overt bad heart failure, and we've transitioned them to a real high-risk case at that point. But all right, so here's a little bit of data, a little bit of literature, but historical perspective on why we worry so much about severe aortic stenosis, because it has a very poor prognosis without surgery. So if you follow patients who have severe aortic stenosis and they get surgery, they continue to live, pretty slow drop-off rate. Follow the patients that didn't get surgery, they die quite quickly. So you can see at 2 years, and these are standard surgical risk patients. Almost 50% of patients are dead. For people at increased risk for surgery, at 1 year, 50% of those patients are dead. So 80-year-old with severe stenosis, if they're asymptomatic, but who might be symptomatic, 50% chance of not making it over the next year. And probably, well, I just hate when people give lectures to me and they say, as you remember, means you don't remember, but I'm going to tell you and make you feel like you should remember. So as you probably don't remember at all, this is a Braunwald slide, and so with the classic teaching of the latency period, and after about 60 years, people start to become symptomatic with angina, syncope, or heart failure, and then they drop off the curve. And on the board, whether you had angina, syncope, or heart failure, all were linked to a different survival, and so we all memorized those questions, years ago. But that was done in the 1960s, that study. It was done with young patients. So the data really just hold up anymore. Our patients are older, they're more complicated. As I mentioned, asymptomatic patients are rarely asymptomatic. The first presentation of severe aortic stenosis can be the last presentation of aortic stenosis. Syncope, death, never made it to the hospital. People with extremely severe aortic stenosis, meaning a mean gradient of over 50, about it's 40 for severe, they really do poorly. So a lot of little old ladies aren't moving around much, and they're saying, I'm fine, and maybe that's the right decision for them. That it really be. We need to know what their prognosis is. That many patients were very poor candidates for surgery, these elderly sick patients, previous CABG, lung disease, et cetera, Used to be dementia down there. We say dementia anymore because we know dementia and bad frailty don't do well with TAVR either. It used to be the way to get a TAVR when we started, because you could possibly have surgery. But now we know there's certain subsets that don't do well with surgery or TAVR. And we have to discuss with ourselves and the patients about that when they came in. Again, we're not a TAVR program. We're a clinical program. So first TAVR was done in 2002. It's a guy named Dr. Cribbet from France. And supposedly he did a TAVR on this guy who had an ejection fraction of 12%. and everything went well. The movie. Little African music we pumped in for the little background. Yeah. So the severely stenotic aortic valve, we're looking down on it, a lot of calcium there. With a wire coming up down from the back artery. We advance a wire up, and we spend a few minutes trying to find our way through that little tiny opening. That was a good opera there, yeah, got it through. That wire guides the rest of the equipment for the procedure. This is a long stick with a balloon on the end of it, a balloon catheter. First thing we do is stretch open the native aortic valve. We rapidly pace the heart so there's basically no forward flow going on. Take the balloon out, and then we shove this gigantic sheath up, which used to be huge, huge. Now it's down to what we call 14 French, which is a little bigger than it's like a big pencil. So it can most people's iliacs without problem. The little yellow thing on the front is a nose cone. That nose cone helps us come down and pass through the valve. The new valve system is right here. There's a balloon inside there. We rapidly pace the heart again, so it's basically at standstill. Balloon goes up, down, and we pull things back. So that's about a 10-second pacing run. In 10 seconds, we inject dye. We make sure the valve is right where it's supposed to be, and then we cross our fingers and we inflate the balloon quickly. So if we blow, it goes into the ventricle, they die. If we get it dye, it closes off the coronary arteries, they die. Had that happen to us 3 times in 6 years. So it's a pretty system, but those 10 seconds are 10 seconds of excitement. We'll start doing this with patients. We're going to be doing this with patients awake next month. So right, everybody's put to sleep. Okay, I'll get past that. Any question on the procedure? Yes. Yeah, absolutely. So you know, when that valve is stretched open both by the balloon and the new valve, you can get a shower of the brain. So when you take a look at that with MRIs and CTs, you'll see lots of microinfarcts. It's never correlated with any clinical outcomes. 1% to 2% stroke rate per time. So there have been people who've experimented with little filter devices that we put in, but just the process of putting them in causes more complications than just riding it out. So the trial is a famous trial that happened about 6 years ago. That took patients, divided them into 2 groups. Like a bunch of patients who could not have surgery, they were inoperable, and did a TAVR in half of them, and did the other half alone. Okay, so the group that got the TAVR did so much better that the absolute risk reduction was almost 25%. The number needed to treat 4 people to save a life, which is just almost unheard of in medicine. It's like erythromycin for a rabid African rat, you know, 4 of those. That was where it went to. That's where it started. The other group was those who were high risk for surgery, not inoperable. So half of them got high risk surgery, half of them got TAVR, and they're absolutely equivalent. But those TAVR got out of the hospital in a couple of days. So that's how it all started. And that was all on either inoperable or super high risk patients. Learned from that trial that if you ended up with some aortic insufficiency, some back leak around that TAVR valve, that they didn't do as well. More about the numbers. Because of that, these systems now have a skirter on the outside. It's like denture cream. So when you implant that valve, it kind of fills the nooks and crannies, and now we have very, very, very little back leak, very little paravalvular aortic insufficiency. Valve systems, this is a self-expanding one. This is one that expands with a mechanical device. This is another one. And the cyst got so good that someone then decided to test it on intermediate risk patients. Same sort of situation, half got surgery, half got TAVR. For intermediate risk patients, TAVR was not only equivalent, it was actually superior to surgery. You should see Reed Quinn try to say that out loud. It's amazing, but it does, because it's true. So things really took off about 3 years ago when intermediate risk patients were approved. So typical patient, 82 years of age, still hospital, most of the people we work with are very, very elderly. 90% of our patients, we get access through the groin. You can do this by doing a small operation on the chest. Light general anesthesia, they're all woken up right in the operating room. Again, we're going to start doing it with people awake next month. They're a post-anesthesia care unit. Nobody goes to the intensive care unit unless they have a complication. They're transferred to the floor. They leave in 2 days. They're on Plavix for 6 months, aspirin indefinitely. We call them in a week, and we see them in a month. Every one of our patients is seen by the advanced heart failure team while they're in the hospital to treat any diuretics that they may be on, because those guys are better at diastolic heart failure than we are. And we've tried to use that as a way to cut down on rehospitalization rate. So we've gone a little longer than I expected, but the standard workup is pretty quick. At this point, it's a consult with the team. We get an echo, cath, make sure they don't have bad coronary disease. If they have bad coronary disease, we usually stent them. Yes, sir.
How do they feel afterwards? Like, what feedback do you get, 4 weeks out?
Want to take that one?
Yeah, one of my patients I talked to today, she already noticed less shortness of breath getting out of bed and walking in her room. So you take a patient that really has no other major comorbidities and it's truly causing a symptom, usually they're feeling much better. They usually notice more energy and less shortness of breath. If you have some patients who have other comorbidities frail, they may not notice, improvement.
So the question was, because I know you're not on mic, was how much better do people feel? And the question that usually, if they don't have COPD, if they're really obese and sedentary, we try to stay away from those patients anyhow. They usually, their shortness of breath, if it's a root history, it's dyspnea, they're just usually really dramatically improve very quickly. We get a CTA also. So the CAT scan lets us look at the arteries, see if they're big enough. It allows us to look at the calcification pattern around the coronary arteries, the heights of the coronary arteries. If you have a lot of calcium around here and a TAVR valve squeezes that calcium into the left main, you can kill somebody. So we have to be careful about that. There's some coronary heights measurements. So that's basically it for TAVR. Okay. We at quarter of. I can come back another time and do a half an hour on mitrals, or we could do 2 minutes on mitrals now. 2 minutes, okay. So the mitral valve is not nearly as sexy as the aortic valve. It's this big, pillowy, ridiculous thing. It's gigantic. It's these stupid cords hanging off of it, these papillary muscles. It's a mess to try to work with catheters. You get caught in all that stuff. And it degenerates and becomes regurgitant in two major ways. One is that the actual leaflets themselves degenerate, we call it degenerative. And the other way is that they get pulled apart when a ventricle gets sick and dilates. And we call it structural. Now, there's only one study at this point randomizing people between mitral surgery and the mitral clip that we saw at the beginning. That was called the Everest trial. We'll go quick through this. This is how it's done. You put a tube up through the vein in the groin. You go to the right side of the heart. You poke a hole through the atrial septum. You come through it with this device that you can bend down. That's the clip open. You advance the clip down through the valve. Then you pull it back and you try to catch both leaflets. And then you close the clip. This takes a lot longer than TAVR. This is an ultrasound-guided procedure, and it's harder. Make people better, but it's not as dramatic as TAVR. This is hard to understand. Baseline in 4+ is what 80% of the patients start off with in terms of the severity of their mitral regurgitation. So 80% start off with 3 or 4+. After 12 months, 80% of the people are at 1 or 2+. So it's a pretty dramatic improvement. And how do people respond clinically compared to TAVR from your experience?
I'm going to do well.
Okay. I click. It's a long time in lead standing.
It's not a cure,
Yep.
With AF, you get rid of it. With a little bit of health therapy, you're really trying to improve the quality of life.
New down the line is called the Caroline. This is it's sort of a tension ring that we put in the coronary sinus that runs around the mitral annulus. Maybe that you would get a same-sitting TAVR and mitral annular ring done percutaneously for people who have aortic stenosis and mitral regurgitation. And then what's coming down the line eventually will be true mitral valve replacements, so the TAVR equivalent for the mitral valve. Very early in development, they're gigantic systems. The size of the tube that goes through the apex of the heart to advance that into the mitral valve is almost as big as a Coke can. It's gigantic. I don't think we're really doing too much good for patients at this stage with that, but lots of things are moving very quickly. So, you want to just on how to contact you, and we'll finish up.
Yeah. So.
Should give you this because.
Okay. I have some cards up here, but basically we have a referral number 662-4897. Myself and Debbie Courtney are the two valve coordinators. We'll the name. If we can get office to fax over some records, just some office notes, EKGs, echoes, any pertinent medical records. Get the images sent over, and then we'll have our team review it and then start getting the patient in. We do an upfront phone call to all the patients as well, just really kind of explaining who we are and what we do, so they're overwhelmed with the whole process when they come in. But yeah. Good question. So the FDA mandates with TAVR and MitraClip that we see these patients at 1 month and 1 year. So we do a 1 week phone call to make sure everything's going well. We do a 1 month visit and a 1 year visit. We ask after the 1 month visit that the patient go back and see their primary care physician and their cardiologist to get hooked back into them. Oftentimes, once we get the referral, we're kind of like the contact person for the patient through the whole process. So it's very important for us to turn them back over to the primary providers after the 1 month visit. But that's it. Often if you guys have a question, you can, send us the patient's information. You can send us the echo report to review. We're more than happy to review echocardiograms and then give you guys a call whether or not we think the patient's appropriate to see or whether or not, can just be monitored through your office or whatnot.
Hey guys? Oh, yeah.
Yeah.
What about antibiotic prophylaxis for normal procedures?
Yep. So we typically do prophylaxis. So typically if the patient does not have a penicillin allergy, we do amoxicillin grams an hour before.
Forever or for? Yeah.
We do it forever. We do it. Sometimes we talk about stopping after a few months, but I think if the patient doesn't have any complications with it, we just sit for life. Exactly. Any questions?